Okay, so we'll pick up in here where we left off this morning and just kind of finish up with the pediatric integument alterations. So we left off, last thing we were talking about were the bacterial infections like impetigo and scalded skin syndrome. Now we're going to move on to the fungal infections. Which we've talked a little bit about already with the adult population, and the two I should say that I'm going to focus on here for the pediatric population is Tinea capitis, so the scalp, and Tinea corporis, which is ringworm. Tinea capitis is actually the most common infection of children, fungal infection of children. Causative agent, unfortunately, usually comes from our house pets, our cats or our dogs, and rodents. Hopefully, we're not keeping rodents as house pets, but add that into the mix as well. And really what you see here with Tinea capitis on the scalp is lesions that are sort of circular, and what you see through these sort of circular lesions is that wherever it is, if there was hair growing, it actually breaks off the hair there at that site. So the scaling and the raised borders of the lesion itself actually breaks off the hairs, and you see these little broken hairs and sort of alopecia at the site on the scalp, and I have a good picture of that in just a minute. And then Tinea corporis is what we refer to as ringworm. It's actually not a worm at all, so that's kind of a misnomer. It just kind of looks like a worm because it makes these little ring-shaped lesions. So again, unfortunately, house pets, kittens, and puppies are a common source of ringworm that gets transmitted to the children in the house. These lesions for ringworm are red. They're round, scaly patches that spread sort of outward, so peripherally. And as the red sort of lesion grows out, the center looks flesh color. The center is clear. And that's what gives it the ringworm look. And usually this is a little bit different than the Tinea capitis in that this usually occurs in areas where there's not a lot of hair. So Tinea capitis is right on the scalp where there's lots of hair. Ringworm is not. Simple treatment with both of these are antifungals. So here's a great picture of Tinea capitis. The lesion is probably somewhere up in here, as you can see here. But you can see the broken hairs and how it's kind of cut off the hairs here in this site, leaving basically, as I mentioned, partial alopecia. And again, the lesions are kind of slight red, slight erythema, and scaling raised borders. And you see that right here in this section. The greatest age group that sort of is affected by this in the pediatric population is about 2 to 10 years old. Okay. That's it for fungal infections. Viral infections in the pediatric population, there's a few that I'm going to focus on here. One of them is a viral infection called molluscum contagiosum. It's really a really highly contagious viral infection of the skin that actually gets transmitted by close contact. So skin-to-skin contact, sharing towels, sheets, those sorts of things. The virus actually encourages epidermal cell proliferation. So again, the cells kind of build up on top of each other and create these little lesions that are sort of dome-shaped papules. Primarily, you'll see these on the face, the trunk, the extremities, and here's a picture of that. And then the term also that they use a lot with molluscum contagiosum is that they're sort of umbilicated. So that means that there's kind of this dot or this center here, that's molluscum contagiosum. Now, there's no specific treatment for molluscum contagiosum. It is a usually pretty mild affliction, so to speak. It's really, not that harmful, and it usually is pretty self-limiting and clears in about 6 to 9 months. So, yes, you're highly contagious while you have it, and yes, it's there for a long period of time, but it doesn't really cause a lot of damage. It doesn't really, make that much of a difference. Okay. All right, the next viral infection I'm going to mention is rubella, or German measles, or sometimes you hear it referred to as three-day measles. This is a virus. It's an RNA virus that enters the bloodstream through the respiratory route. And usually, honestly, the disease in most children is very mild. And in fact, now there's a vaccine. So really, you're not going to see a lot of children with rubella in our population. You can certainly see it in populations where there's several unvaccinated children, or if you're doing international work, you can certainly have chances to see this in other countries, but you're not going to see it a ton as, say, a pediatric nurse here in the United States. But how it presents if one would get rubella: they have enlarged lymph nodes, specifically in the cervical, so sort of neck area, and post-auricular, which is kind of behind the ear, like mastoid process area. It's also characterized with a low-grade fever, sometimes a headache, sore throat, runny nose, cough. So it looks very similar to like a cold or the flu. But what's different from this in terms of its manifestations is that it also is associated with a very faint pink to red maculopapular rash that's caused by the actual virus disseminating into the skin. So there's as I mentioned, a very sort of characteristic rash that's associated with some of these other symptoms. As I mentioned, yes, there is a vaccine for rubella. Vaccination for rubella is often combined with the mumps and the rubeola. So MMR is the term or the name of the vaccine that, again, if you're a pediatric nurse, you'll be giving that a lot. MMR, measles, mumps, rubella. And then there's really, again, no specific treatment for rubella. Recovery is spontaneous, it's self-limiting. What's interesting, though, to keep in mind is that the lymph nodes may remain enlarged and tender for weeks after the illness. So they can really stick around for a long time, even after the illness is gone, and even after the the patient feels better. The lymph nodes can stay large. So I say that because you don't want to necessarily freak anyone out because they have these enlarged lymph nodes. So that's something to keep in mind in terms of education. Oh, and then back to the maculopapular rash. It's sort of a flat, fine, pink rash. I didn't really define that whenever we were going through that. Okay, so by the first day, here's the rash. The rash is usually pretty discreet, and you'll see it more on sort of the upper part of the body. By the third day, or sort of the end of the virus, you'll see it a little bit more spread out, and it's on the lower parts of the body. So lower part of the upper extremity, lower part of the lower extremity. Another viral infection that you may or probably will not see all that much is rubeola. It's also an RNA virus, an RNA virus. This is characterized by a high fever that lasts about 5 to 7 days, and then you can see some of the other manifestations of that. The barking cough it literally sounds like a Great Dane is barking in your house. It has to do with the respiratory manifestations that you see with rubeola or measles. That's, by the way, what rubeola is. It's measles. And usually because of restriction and edema in the airway. So that's something to keep in mind as well. Transmitted by direct contact with droplets from infected people, so it is droplet precaution. And again, usually lasts for about 5 to 7 days, and because it's a virus, it's usually pretty self-limiting. So you're just kind of treating with, symptom-based treatments. And then roseola. So this is a virus that's characterized by fever and this red, very macular, flat, non-raised rash that lasts about 24 hours, usually after the fever breaks and after the patient is feeling better. Roseola is something you see very commonly sort of after a person or a child has gotten a virus, where they're feeling better, they've had a runny nose, they've had a fever, they've had a cough for several days, now they're feeling better, and 24 hours later the mom's putting them in the bathtub and they notice they have this very fine macular rash kind of all over their body, mostly on their trunk and back and sort of mostly trunk and back and lower extremity. And they're like, oh my gosh, what's happening? They're finally feeling better and now they have this new rash. Oftentimes they'll bring them into the doctor and one of the very first questions that you would ask is, have they had a fever or a runny nose lately? And if the answer is yes, and now 24 hours later they have this fine red macular rash, it's probably roseola. So it's very self-limiting. There's nothing you really need to do about it. And actually, interestingly, as I mentioned, this rash kind of pops up after a virus, so sort of post-viral. And usually when they have roseola rash, they're actually not even infectious anymore. The infectious period is actually over by the time they break out in the rash 24 hours later. And then chickenpox, again, varicella. We don't even see this all that much anymore because now there is a vaccine for chickenpox. But it's a highly contagious DNA virus that's spread by close person-to-person contact and specific airborne droplets. So there's two ways you can initially be infected with chickenpox, both person-to-person contact, so actually touching, but then also in the air as well. Again, first signs of illness include fever, itching, appearance of like those vesicles, those clear little blisters that appear to have, they're fluid filled on the face, trunk, and scalp. Really, especially in children, if they get chickenpox, it's a very uncomplicated infection. It really doesn't require anything but just letting it right out. Now, interestingly, if an adult somehow gets through childhood without getting chickenpox, and they get chickenpox as an adult, adult symptoms and adult illness tends to be much more severe and much worse, and they're a lot sicker. But usually, under normal circumstances, if a child gets chickenpox, it's pretty uncomplicated, and they really just kind of write it out. But again, nowadays, there's a vaccine available, so it's going to be one of those things that's kind of like part of history, like measles and mumps. We're really not going to see chickenpox all that often anymore. And again, here's a chickenpox rash, the way it sort of looks. The rash is relatively profuse on the trunk and not so much on, a little bit more sparse on distally, so on the legs and on the arms. So you're going to see it most on the trunk, the back, the face. Lots of itching. You want to try to put some sort of emollient on it, like a calamine lotion or an anti-itch lotion on the actual vesicles, if you will, because you really don't want the child to scratch. A lot of scratching is really the only way that you ever would sort of get scarring from the lesions of chickenpox. Usually they don't leave any sort of residual scarring behind, but again, unless there's a lot of intense scratching going on and you kind of break open those lesions, then there can be some scarring, some permanent scarring. All right. Moving on to insect bites and parasites. Let's talk about some insect infestations. Fun. All right, so the first one I'm going to talk about is scabies. This is a contagious disease that's caused by the itch mite. It's transmitted by personal contact, so touch, and also infected clothing and bedding. And what happens here, and I really didn't have a lot of experience with scabies until I actually did some work in Honduras, and then I got to actually see a lot of it. What happens here is that the female mite tunnels pretty shallowly into the skin, millimeters to a centimeter into the stratum corneum, deposits eggs, so actually lays the eggs, and over about a 3-week period or so, the eggs actually mature into adult mites. So the eggs break open, you've got adult mites, and then they sort of crawl and tunnel under the skin and deposit more eggs in different places. So it actually, if you've ever seen the sort of the way that mites look in the skin, it almost looks like a constellation, or sort of connect the dots. You see this area of a lot of little red dots, and then you'll see like a line of where they traveled or where they tunneled through the skin, and then went to another place and laid down more eggs. And so then you see again this deposit of these little red dots and these red itchy bumps in this other area. It's very sort of connect the dots looking picture when you see it. And again, the primary lesions are burrows. They actually burrow down into the skin, so you can sort of actually see, with the naked eye, you can actually see the burrows when you're looking at the skin, the little tunnels that they've created. And then you have these sort of papular vesicular lesions with a lot of severe itching where they've actually laid the eggs. And because it is so severe and such an intense itch, the patient really is at risk for sort of secondary infections because they scratch the heck out of that area and they actually open up the skin. It's very uncomfortable, it's very inconvenient, but it's not life-threatening. Treated with application of scabicide. So whenever I was in Honduras, we actually, at the clinic that I was working at, would just hand out like the specific body shampoo that was for both hair and skin that actually got rid of scabies, and we would just kind of hand it out like in a goodie bag sort of as we were discharging patients to sort of have on hand because it was pretty rampant where we were. And then you'll also have to do a lot of education in terms of cleaning every surface in the house, washing linens, changing out towels, not sharing, I mean, just basically an entire overhaul of the home. Very similar to how you would clean, if there were lice, if you had a presence of lice in your house. Unfortunately, you're going to see this more commonly in places that maybe aren't as clean. There are really close quarters, and then it can run pretty rampant because, like I said, it's on your linens, it's on your furniture, it's on your towels, and so you have to really be careful about your education about how and when to get rid of them. And here's a picture of a scabie, and then here's the actual pictures of the sort of the areas that you would see in terms of where they've laid the eggs. Now, this looks a little bit different than what I saw in Honduras. Yes, I saw these big sort of vesicles, but then in between, it's kind of hard to see in this picture, but in between, you would see like these little tracks, like these little connect the dot tracks in between these, where you could actually have, you could actually see where the scabies have actually traveled from point to point. So it was almost like a constellation or a connect the dots, if that makes sense. All right. The next lovely topic of insect bites and parasites is pediculosis. So this is lice. And you can have pediculus capitis, which is head lice, which is what we sort of think of here in the United States, like in schools and daycares and things like that. Body lice, and then crab or pubic lice. This is actually a highly contagious parasite that survives by, as we know, actually sucking the blood of the person in which they've infested. So again, you can acquire these lice through personal contact, so touching, head to head someone who's got head lice, or sharing any of the sort of shared clothing, combs, brushes, softer cushion-based furniture, things like that. They don't really like hard surfaces, but you really should still clean all surfaces when you have a lice infestation. You treat lice with pediculicides, so again, kind of a specific type of shampoo, specifically when we're talking about head lice. Lice, interestingly, do not like oil. So a lot of the shampoos and soaps that are used to get rid of lice are strongly oil-based. So basically it just kind of suffocates them. They can't really survive and breathe through oil. And so what happens is they suffocate with this particular type of oil-based shampoo or soap. They die. And then unfortunately what you have to do is actually, when they're in the hair, for example, you have to pick them out. You have to go through and sort of comb and pick all of them out after they've died from this, specific type of shampoo. And then in terms of your house, again, clothes, towels, bedding, brushes should all be washed in really, really hot water. And again, they don't like hard surfaces, so that's one help, is that you really should just stick with like couches and upholstered furniture and chairs and things like that. This is actually a picture that I forgot to take out of here. This is actually a picture of a little baby with flea bites, so just disregard that. All right. And then the last insect infestation we're going to talk about is bed bugs. So this is interesting. They actually live in crevices and cracks of floors, walls, furniture, and of course bedding or furniture stuffing. They're very actually able to see with the naked eye. They're 3 to 5 millimeters long, so you can actually see them. They're kind of these sort of oblong, reddish brown little lovely creatures, and they oftentimes will feed in the darkness. So they stay in the cracks of the floors, the walls, the furniture, the bed specifically. And then when the lights are off and you're laid down in your bed and you're going to sleep, they actually come out and feed in the darkness. So they attach to the skin, suck the blood of the person that they've attached to, and leave. The lesions that they leave behind are these red macules that develop into nodules. So they get kind of hard and cystic and very itchy, and actually more, not only itchy, but painful. Very interestingly, whenever I was working and living in New York, I don't know if you've heard about it, but several years ago there was a really huge bed bug infestation in New York City. And so I was seeing, there was a time there in the ER where I was seeing lots of it. And lots of them were poor tourists that came to like have a good time in New York City, and then they're ending up in the ER because they've got these wicked bed bug bites. And what was happening and why, and again, this was not happening in just, poorly sanitized, unclean places. These are like happening in nice hotels, happening at the Plaza, happening at the, I think actually one of the big infestations was at the Waldorf Astoria. So like really, nice hotels. What was happening is when people were getting new mattresses delivered to their home, the mattress company that would come deliver your nice new big pretty expensive mattress would take your old mattress from you and put it in the back of the truck where all the other new pretty expensive mattresses were, and they were infesting all of these brand new from the factory mattresses that were being delivered newly into people's homes and into hotels. And so it was rampant. I mean, there were just, everybody had bed bugs. It was like, you got bed bugs, I got bed bugs, everybody's got bed bugs. In New York, it was really a crazy time. And like I said, we work here in the ER, and you have all these poor tourists come in just eaten up from the mattresses in the hotels that they were staying in. So it was really kind of crazy. And now, I'm super crazy about looking at the mattresses and pulling the sheets back and looking in the little creases of the, where the lining meets the mattress and all of that, because you can actually see them. It's not like, oh, you're just guessing. You can actually see them and know whether or not, the bed you're going to be sleeping in has bed bugs or not. So you'll never go to a hotel the same way again, right? So interesting little side note on bed bugs. Okay, so now that you're wonderfully itchy and sitting there scratching yourself and feeling like you've got things crawling all over you, now I'll change the topic and we will move to hemangioma. So this is the last topic here of the pediatric population that we're going to talk about. So hemangioma is just the word itself. Is an abnormal vascular growth. And what I mean by that, it could be just the capillaries, it could be the actual sort of big blood vessels themselves. And so there's several different types of hemangiomas, or two different types of hemangiomas that we're going to talk about. The first one is something called a strawberry hemangioma. This is a raised, very vascular lesion that usually sort of emerges, and you start to notice it about 3 to 5 weeks after a baby is born. And the reason that they form, and sort of the pathophysiology behind these strawberry hemangiomas, is that they form from rapid growth of the vascular endothelial cells, which result, honestly, into extra blood vessels. So you actually have more blood vessels, more capillaries in one particular spot that's very concentrated and superficial. So what happens is the lesions proliferate, and they become bright red and sort of elevate because of these small capillary projections. So that's actually kind of this raised, really bright red, beefy red type of lesion. And I'll actually kind of skip forward here for you and show you a picture so you can kind of see it as I'm talking. So this one here on the left is a great picture of a strawberry hemangioma. You'll see these, you see this one sort of on the eyelid. Sometimes you can see these on the head. Actually anywhere in the body. And what's interesting about these is that about 90% of these disappear by about 5 to 6 years old. So they almost like sort of grow into them, so to speak. And they just kind of, are self-limiting and disappear. The abnormal sort of vascular sort of makeup in that area just kind of, the baby kind of grows into it, and they just kind of disappear by about the age of 5 to 6 years old. Now the other hemangioma is called a cavernous hemangioma. Now these are usually present at birth as opposed to emerging sort of 3 to 5 weeks after birth like the strawberry hemangioma. But cavernous hemangiomas involve larger and more mature vessels than the strawberry hemangioma, so we're not just necessarily talking about capillaries, these little capillaries with cavernous hemangioma, we're talking about larger, more mature vessels. So they actually cause more of an actual malformation. Now again, interesting like this, they grow very rapidly from about birth up to about 6 months, and they basically mature by about 1 year of age and gone in 90% of children by the age of 9. So again, they just kind of stop growing rapidly, the baby kind of grows into the blood vessels, you know, kind of match the same shape and size of the vessel, and they just kind of go away. They're sort of self-limiting. Specifically, as I mentioned, 90% of them are gone in children by the age of 9. Again, very superficial, but temporary. And here's a picture on the right here of a cavernous hemangioma. So it actually makes more of an actual malformation wherever a cavernous hemangioma forms, but again, usually subsides and goes away on its own. Okay. Now, the next slide I'm going to talk about are vascular malformations. So these are rare congenital anomalies of blood vessels that are present usually at birth, but may not necessarily be apparent for several years. And these are either port wine stain or salmon patches. And usually, especially the port wine stain, is different than the strawberry or the cavernous hemangioma in that they usually don't go away. So they're usually pretty permanent, almost like a birthmark. It's a congenital, so a port wine stain is a congenital malformation of the dermal capillaries. And what it presents as is this very flat pink to dark reddish purple lesions. So I'll show you a picture. Here's a good picture of a port wine hemangioma. Again, basically just kind of like a birthmark. This is not going to go away. This is probably permanent. And again, due to a congenital malformation of some of the dermal capillaries. And then to go back. Salmon patches, similar to port wine stains. They're macular, so they're pretty flat as well. Pink lesions resulting from distended dermal capillaries. Now these are a little bit different, and then they usually do fade by about 1 year of age. So I'm sorry if I confused you. Port wine stains usually do not go away. They're pretty permanent, kind of like a birthmark. Salmon patches usually fade by about 1 year of age. So they may not completely go away, but they're certainly fading and a little less noticeable. Very common on the nape of the neck, the forehead, upper eyelids, or the nasolabial folds in children. Oftentimes the salmon patch on the back, sort of on the nape of the neck, is referred to as a quote-unquote stork bite for babies. But again, they either sort of fade and you don't notice them, or especially if they're sort of on the head or the nape of the neck, you know, you don't even really notice them after about 1 year of age because they're growing hair and they just kind of get lost into the head of hair. So that is the salmon patch versus port wine stain. Okay. And that concludes the slideshow. So again, not much more information there, but I just wanted to make sure we covered all the topics. And now you have the information that you need to study and get ready for the final. Thanks, guys.